Hello, in this video we will discuss CV Junction Craniometry. Craniometry involves using various measurements on CV junction to identify various pathologies. Now moving on, we will first discuss lines associated with basilar invagination. But first we need to differentiate basilar invagination from another term, basilar impression. So, basilar invagination is a congenital form of occipital hypoplasia which manifests by prolapse of the spinal column into the skull base, whereas basilar impression is upward displacement of dens due to acquired softening of bones at the base of skull, leading to skull base flattening. Now there are various conditions in which basilar impression can be found. These include osteogenesis imperfecta, rickets, Paget's disease, hyperparathyroidism, Hurdler syndrome, skeletal dysplasias. Basilar invagination is also associated with Down syndrome and skeletal dysplasias. Now these are the syndromes with which basilar invagination and impressions are associated, but they are not the only list. There will be long list, but these are the most common with which I generally keep in my mind. Now moving on to craniometric lines for basilar invagination. First line is Chamberlain's line. So you can see the orange line here. It is drawn from opistheon to the posterior end of hard palate, and if the tip of dens is greater than 3 mm above this line, then basilar invagination is present. Next line is McGregor line. So McGregor line is a modification of Chamberlain's line. It is generally used when in plain radiograph we are not able to identify opistheon. So McGregor line refers to a line connecting posterior edge of hard palate to the most caudal portion of occipital curve. Now if tip of dens is greater than 4.5 mm above McGregor line, then basilar invagination is present. Then third line is McRae's line. So McRae's line is a line which joins opistheon to passion. Normal values for McRae's line is average around 35 mm in sagittal section. However, if sagittal diameter is less than 20 mm, then there is presence of foramen magnum stenosis. The tip of odontoid never crosses this line. If it crosses this line, then basilar invagination is present. Normally, the tip of odontoid is around 5 mm below this line. Now, third craniometric line is height index of claws. So it is a distance between tip of tuberculum or tip of dens and tuberculum trocula line. So first we will draw a line from tuberculum to trocula, and then we will draw a perpendicular from tip of dens to this line. Normal value for height index of claws is 40 to 41 mm. Minimum value which should be there for not to say that there is basilar invagination is 30 mm. If it is less than 30 mm, then basilar invagination is present. If it is between 30 to 36 mm, then there is tendency towards basilar invagination. In that case, we may need to use other parameters to see if basilar invagination is present or not. Now next kinematic parameter is Bull's angle. So Bull's angle is an angle which is formed between a line which is drawn backwards extending from the hard palate and another line which is joining the midpoint of the anterior and posterior arc of atlas. So if it is greater than 13 degree, then basilar invagination is present. If it is between 10 to 13 degree, then there is tendency towards basilar invagination. Moving on, next line is Ranawat's line. So Ranawat's line, how we draw it? So first we will draw a line joining the midpoint of anterior arc of atlas and posterior arc of atlas. Then we will draw a perpendicular on it from the center of C2 pedicle. Now normal for this is 17 millimeters in male and 15 millimeters in female. If it is less than 15 millimeter in males or less than 13 millimeter in females, then basilar invagination is present. If it is less than 7 millimeter, then there are chances that there is a medullary compression. Next parameter is Clark's station. So for Clark's station, we will divide odontoid into 3 equal parts: station 1, station 2 and station 3. Anterior arc of atlas generally lies in station 1. If it is lying in station 2 or station 3, then basilar invagination is present. Next criteria is Redlen-Johnel-Peterson criteria. So how do we draw this line? So first we will draw a McGregor line. Remember, McGregor line is a line which is drawn from the posterior end of hard palate to the caudal most part of the occipital curve. The second line in Redlen-Johnel criteria is a line which is drawn from the midpoint of the caudal margin of second cervical vertebra perpendicular to the McGregor line. Now if it is less than 34 millimeter in males or less than 29 millimeter in females, then basilar invagination is present. Next line is Wackenheim's line. So Wackenheim's line is a line which is drawn along the slope of Clivus extending into the cervical canal. Normally tip of dens should not intersect this line. If tip of dens intersects this line, then basilar invagination is present. In anteroposterior view, we have digastric line, which is also called as biventer line, and bimastoid line. So digastric line is a line which is drawn from one digastric notch to the other digastric notch, and bimastoid line is a line which is drawn from one mastoid tip to the other mastoid tip. Now what is the significance of these lines? So for bimastoid line, the tip of dens should not exceed 10 millimeter above this line. If tip of dens is extending 10 millimeter above this line, then basilar invagination is present. Digastric line. There are various ways to interpret it. So the distance from digastric line to that of tip of dens is normally 11 millimeter. But then morphology of dens can vary. So comparison of digastric line to the tip of dens to conclude whether BI is present or not is not much reliable. Anyways, if this distance is less than 11 millimeter, then basilar invagination is present. Other way to interpret is to draw a third line which joins the midpoint of Atlanto-occipital joint. So the distance of this Atlanto-occipital joint line to the digastric line should be 10 to 12 millimeter. If it is less than that, basically if it is less than 10 millimeters, then basilar invagination is present. Now coming on to another entity, Platybasia. So for Platybasia, first line is Bogaerts line. This is a line which joins Nasion to Opisthion. Normally Basion should lie below this line. In basilar impression or Platybasia, Basion will be above this line. Then second parameter is Bogaerts angle. So it is an angle between plane of Clivus and Macrae's line. Normally is 126 plus minus 6 degree. However, if it is more than 135 degree, then basilar impression or Platybasia is present. Next angle is basal angle. So basal angle is called by many names like basicranial angle, Welshire angle and Martin's angle. I was not able to find if there is any difference in the ways of measurement of Welshire basal angle or Martin's basal angle or basicranial basal angle. So for measurement of basal angle, a line from Nasion to the center of Silla is drawn and another line from center of Silla to Basion is drawn, and this angle is called basal angle. So some authors say that it is a line where first line is drawn from Nasion to tuberculum Silla and then from tuberculum Silla to Basion, and some other authors say that it is a line where first line is drawn from Nasion to dorsum Sillae and then second line is drawn from dorsum Sillae to Basion. But most of the articles and books have given it to be the center of Silla. There is also confusion about the range of this angle. Most of the authors say it lies between 125 to 143 degree. Some authors says that it lies between 120 to 150 degree. So if basal angle is more than 143 degree, or you can say more than 142 degree as per some authors, then Platybasia is present. Some authors have told that Platybasia happens when basal angle is more than 152 degree. So it depends on person to person and their interpretation. So you should know all these values. Platybasia as such doesn't require any intervention unless and until conditions which arise because of Platybasia like basilar impression is causing medullary compression, brainstem compression. Now if basal angle is less than 125 degree, then there is basilar kyphosis. So basilar kyphosis means that skull will be kyphotically angulated. So it's basically like there will be kyphotic skull. If basilar angle is less than 130 degree, it is generally found in achondroplasia. So less than 125 will be generally found with achondroplasia also. Now moving on to next line, it is next angle, Wagenheim's angle. It is also called as Clivus axis angle. So it is an angle between line along the slope of Clivus and other line along the posterior marginal line along the axis. So next angle is Wagenheim's angle, also called as Clivus axis angle. It is angle between line along the slope of Clivus and second line from the posterior marginal line along the axis. So normally it is greater than 150 degree. It can be more than 180 degree in extension. However, if it is less than 150 degree, then we say that there is a presence of craniocervical kyphosis. And suppose if this angle is less than 125 degree, then there is highly likely that bulbar compression is present. Now moving on to next section, Atlanto-axial instability. So one of the most common lines for Atlanto-axial instability is Atlanto-dental index. So it is a line which is drawn from the posterior edge of atlas to the anterior margin of axis, basically anterior margin of dens. So in less than 8 years of age, it is generally taken as normal value to be less than or equal to 5 millimeter, and for greater than 8 years of age, normal value is less than 3 millimeter. Some books say that normal value should be taken as less than 2.5 millimeter in females. So for Atlanto-dental index, if the values are between 5 to 6 millimeter in patient who is above 8 years of age, then it means that transverse component of cruciate ligament is disrupted if the value is between 5 to 6 millimeter. If the value is more than 6 millimeter, then it means that alar ligament is also disrupted along with transverse component of cruciate ligament. And if value is more than 9 millimeter, then there is most likely cord compression. Other line which is used in Atlanto-axial instability is posterior Atlanto-dental index. So it is a line joining the posterior margin of dens to the anterior margin of posterior arc of atlas. Now this line, posterior Atlanto-dental index, is generally useful in conditions like rheumatoid arthritis or in conditions like Down syndrome or in conditions where there is ligamentous laxity. So if this value, the value of PADI, is less than 14 millimeters, then it predicts cord compression. Now next parameter which is used generally for occipital condyle hypoplasia is Smith-Fisher angle. It is also called as angle of Atlanto-axial joint. So what is Smith-Fisher angle? A Smith-Fisher angle is an angle which is made by two lines which runs along the axis of Atlanto-occipital joint. So this area is Atlanto-occipital joint. This area is Atlanto-occipital joint. So the line which is running along this axis on both sides, these lines join together to form Smith-Fisher angle. Normal value for it is 125 degree plus minus 2 degree, and if it is more than that, then there is a presence of occipital condyle hypoplasia. Now moving on to next line. This line is called as PBC2 line, or we can also call it as Grab-Oaks line, or we can also call it as Grab-Oaks line. So how to draw this line? For drawing this line, we need to understand what exactly this line is. So it is a line which tells us about retroflexion of odontoid. So how to draw this line? So to draw this line, we'll first draw one line from basion to the posterior inferior aspect of dens. From basion to the posterior inferior aspect of dens. Then we will draw a second line which is perpendicular to the first line, and it goes and meet the anterior margin of dura. So here basically you can say it to be this line, or you can say it to be this line. So it's not exactly given that from where to draw the second line. What is written is that it is drawn from the superior posterior aspect of dens. So what is the importance of this line? So in normal population, it is generally less than 9 millimeter. It is rarely more than 9 millimeter in normal population. So if a patient is undergoing foramen magnum decompression for KRA1 malformation, and this line is less than 9 millimeter, then it is most likely that patient will have improvement in most of his symptoms. However, if it is more than 9 millimeter, then according to Bengel's spine surgery, patient should undergo occipitocervical fusion. Now that's all. These are all the lines which I wanted to discuss in CV Junction Craniometry. So you can go through them when you will go through the books. There are various variations in the values which are given for these lines. What I have done in this video is to find the values which are given in most of the books, and if there is any controversy about the values, that also I have presented here. So there can be slight variation in these values, but basic concept of these lines is what I have told. Hope it will help you in your further studies. Hope this will improve your understanding of these lines. Thank you.